Welcome to Medicine Master Academy, and today we will discuss a common pediatric clinical case you might encounter in your exam. A 6-month-old boy is brought to the pediatric clinic by his parents, who report that he has episodes of turning blue, especially while feeding or crying. They also notice that he becomes short of breath during these episodes. His growth and development have been slower compared to his older brother. On physical examination, a systolic ejection murmur is heard at the left sternal border, and the baby's oxygen saturation is noted to be low. Echocardiography confirms a diagnosis of tetralogy of Fallot. What is the most likely cause for the episodes of cyanosis seen in this patient? A. Left to right shunting of blood through the ventricular septal defect. B. Right to left shunting of blood through the ventricular septal defect. C. Pulmonary hypertension. D. Systemic hypertension. E. Increased pulmonary vascular resistance. The correct answer is B. Right to left shunting of blood through the ventricular septal defect. In this patient, we have a classic case of tetralogy of Fallot, which is a congenital heart disease characterized by 4 key features: ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. Now, the way these defects interact leads to the main issue we're discussing, which is cyanosis. The episodes of cyanosis, or the blue discoloration, are due to what we call a right-to-left shunt. This happens when the blood bypasses the lungs, where it should be picking up oxygen, and goes straight to the rest of the body. Let me break this down. Firstly, the pulmonary stenosis in tetralogy of Fallot leads to a higher pressure on the right side of the heart compared to the left side. And remember, we have a ventricular septal defect, which is essentially a hole in the wall between the 2 ventricles. This difference in pressure causes the deoxygenated blood in the right ventricle to shunt or move across this hole to the left side of the heart. This deoxygenated blood then gets pumped out to the body, leading to cyanosis or to the bluish color, especially noted in areas like the lips and under the nails. Now, let's talk about why the other options are not correct. Left to right shunting is usually seen when the pressure in the left side of the heart is higher than the right, like in conditions where you only have a ventricular septal defect but without any obstruction on the right side. This is not the case in tetralogy of Fallot. Pulmonary hypertension, or increased pressure in the lung vessels, and increased pulmonary vascular resistance can indeed lead to cyanosis, but they are typically not features of tetralogy of Fallot. Here, the main issue is not high pressure or resistance in the lung vessels, but the obstruction in the right ventricular outflow tract due to pulmonary stenosis. Systemic hypertension, or high blood pressure throughout the body, doesn't cause cyanosis. Cyanosis happens when deoxygenated blood is sent to the body, which isn't directly related to the blood pressure levels in the body's systemic circulation. As for the option suggesting increased pulmonary vascular resistance, this generally refers to a condition where the arteries that carry blood from the heart to the lungs become narrow, stiff, or thicken. In such a case, the heart needs to work harder to pump blood through, leading to a higher pressure in these arteries. In some situations, like persistent pulmonary hypertension of the newborn, this increased resistance can indeed lead to a right-to-left shunt, causing cyanosis. However, in tetralogy of Fallot, the primary issue is the obstruction in the right ventricular outflow tract due to pulmonary stenosis, not increased resistance in the lungs' blood vessels. This video will help you understand the dynamic of the heart and why pediatric patients with tetralogy of Fallot develop cyanosis. Follow us for the next clinical case.
For more information about our courses and ebooks, visit our website.